Okay, well, welcome everybody back to our next session, session 4, and we have a great session ahead of us, an update on viral targets for HBV and HDV therapy, and we're going to have a number of relatively short talks, but as we've seen today, lots of data packed into short time. So I'm going to turn it over to Massimo to introduce our first speaker.
So it's my pleasure to introduce Barbara Testoni. She is a group leader at the INSERM in Lyon, in the lab of viral hepatitis, and she graduated in Rome, actually, she got the PhD in the University of Milan, and then moved in Rome as a postdoc. And she stopped to work to what was doing at that time and started to work on hepatitis B. And she's really engaged in understanding cccDNA biology and even more translational aspects, and she will talk about that today.
Exactly. Thank you very much for the kind introduction, Massimo. Thank you very much to the organizing committee for the invitation. So today I will focus on cccDNA transcriptional activity and biomarkers. So why do we need a biomarker for cccDNA transcriptional activity? So when you talk about cccDNA is a dynamic epigenetically regulated molecule. So we have to talk about the quantity of cccDNA, but also how many RNA molecules are produced from each cccDNA molecule, which is the transcriptional activity. And this transcriptional activity can vary across the natural history of chronic infection, but also potentially during antiviral therapy, as we have demonstrated in long-term tadbudin treated patients whose cccDNA acquire negative epigenetic marks and have less amount of progenomic RNA. So when we talk about functional cure, we are aware that cccDNA is still on the liver, but we want to be sure that it's functionally inactive, so the transcriptional activity is no more there. So the gold standard, of course, is to look in the liver, to quantify cccDNA and transcriptional activity, but with obvious limitation of the invasiveness, sampling bias, and technical challenges. So to have a non-invasive biomarker would be really helpful for that. So correlated antigen, where does it come from? It is translated from overlength HBV RNA pregenomic and pre-core, and so only produced from cccDNA, and it recognizes the core protein and HBe antigen and the pre-C or P22CR, which keeps the N-terminus but lacks the CTD. So we have one available assay, commercially available assay, which is the CLIA correlated antigen assay kit from Fujirebio. And this is the kit that is available in Western countries. It has 3 steps: a capture, a pre-treatment with detergents with also dissolved immune complexes, and a detection step. And the LOQ is 2.8 log units per ml. So there's another test that has been recently published, but is only available in Japan so far, and it is almost 1 log more sensitive. So it's clear that correlated antigen is positively correlated to the cccDNA pool in the liver, and it is well summarized by this meta-analysis study. But very few studies looked at the intrahepatic cccDNA transcriptional activity and correlated antigen. The first one was by Honda and colleagues, who showed that in an Asian NUC-treated CHB patients cohort with patients who were positive for correlated antigen had higher intrahepatic RNA, but similar levels of cccDNA. And we had the same results in a Caucasian cohort of untreated patients. So patients having the same amount of cccDNA being negative for correlated antigen had less RNA in the liver and less cccDNA transcriptional activity independently of E antigen status. Moreover, correlated antigen was highly correlated with both RNA and transcriptional activity in the liver, in the overall cohort, and particularly in the HB antigen negative patients. But more interestingly, when we looked at the unsupervised principal component analysis, you can see that correlated antigen was able to identify a subset of e-antigen negative patients in pink in the left below panel that you can visualize in the heat map, and these patients had the highest levels of transcriptional activity among HB antigen negative patients, and also high fibrosis and necroinflammatory activity. And importantly, these patients couldn't be identified looking at serum HBV DNA and HBs antigen alone. So to summarize, correlated antigen correlates with cccDNA transcriptional activity, might help in discriminating more active HB antigen negative patients, but it's limited in the use of HB antigen positive patients because it also recognizes e-antigen. And in our study, 1/3 of the patients, HB antigen negative patients, were negative for correlated antigen, but they all had transcriptionally active cccDNA in the liver. So probably we need for much better sensitivity for this assay. As a footnote, correlated antigen has been validated using dried blood spots, so it can be implemented in the resource-limited settings. This is very important because the technique is minimally invasive, doesn't need cold chain, is genotype independent, and really can help identify viremic individuals who need antiviral therapy in this setting. So going to serum HBV RNA, so here comes the troubles, the complexity. So serum HBV RNA can come from cccDNA, but also from integrated sequences. So 3.5 kb RNA is only transcribed from cccDNA, and it has been shown that encapsulated pgRNA is the predominant form of circulating HBV RNA. So the first studies looking at serum HBV pgRNA were done using qPCR or digital PCR in this region of the RNA, which is at the beginning of the pregenomic RNA. And this is a region which is not shared with the other transcripts. And Wang demonstrated in 47 Asian nuc-treated patients that this quantification correlates with the intrahepatic RNA and cccDNA transcriptional activity. The group of Maura Dandri demonstrated the same in a humanized mouse model, also demonstrated that serum HBV RNA was not affected by nuc treatment, but was decreased by interferon, which is known to decrease the cccDNA transcriptional activity. And then Wang again also demonstrated this correlation in treatment-naive Asian patients. But since then, a number of publications demonstrated the complexity of circulating HBV RNA species. So not only pregenomic RNA, a lot of splice variants that can really vary in quantity and heterogeneity across phases, a certain heterogeneity at the 3' end of these RNA that can be truncated, polyadenylated or not, also in correlation with nuc treatment, the presence of HBx RNA, and also the fact that capsids and virions were not the only shuttling elements of RNA in the serum. But also a complexity of the serum HBV RNA assay that has been used across all the studies that have been published. So it's really difficult to catalog all of them. So a heterogeneity in the primers and probes that were used, heterogeneity in the techniques used, but I want to really make a point on two commercial RNA assays that are now available. So the first one is the Abbott one, which was the first to be described. So it is designed with the two set of primer and probes, the one in a conserved region within the 5' end of the X gene, and the other one in the 3' end of the core gene. These two targets, very important, are independently detected, meaning that they are not necessarily on the same molecule when they are detected. It's genotype independent, and the calibration is done on a DNA standard. So Abbott demonstrated that the results for the X and core target was really comparable among all the patients that they analyzed, both nuc-treated and untreated, and also in longitudinal individuals. So the second assay is a Roche HBV RNA investigational assay for the COBAS system. In this assay, the primers and probes are located across the 3' end canonical polyadenylation signal, which is lost in integrated HBV DNA. Just theoretically recognizes only RNA coming from cccDNA. So the assay doesn't need any DNase treatment before the quantification. It's validated across genotypes. It gives the same results in serum and plasma. It's completely automated, but a manual assay is also available for laboratory testing and has the same efficacy of the automated one. So the cobas is calibrating on an armored RNA, which has been quantitated by digital PCR. So the two tests were compared to an in-house race PCR, which was developed by Van Bommel in 2014, and both of them showed a good correlation with this in-house PCR and superior sensitivity. However, a comparison between the two Abbott and Roche assay really needed the implementation of an international standard for HBV RNA. In this context, we are working toward it together with Massimo, and we were able to establish the clonal cell line secreting high quantities of HBV RNAs. These cell lines has mutations in the pol operating frame in reversing the ratio between HBV DNA and RNA, and the majority of this RNA is contained in virion and innate capsids, and single-cell molecule sequences demonstrated that this RNA is majority pgRNA and xRNA, and this assay is suitable for usage on the Roche automated and manual assay. So we extensively validated the correlation of the Roche assay with intrahepatic cccDNA transcriptional activity in a cohort of 100 untreated chronic hepatitis B patients. I show you, for the sake of time, only the results for the HB antigen negative patients, and you can clearly see that patients who were positive for serum HBV RNA had higher intrahepatic RNA and cccDNA transcriptional activity, and serum HBV RNA correlated very highly with these markers and also with correlated antigen, but not with HBs. Moreover, the same results were obtained in a cohort of long-term NUC-treated patients that were eligible for liver transplantation and had undetectable viral load. So all these patients had a positive detection of HBV DNA RNA in the native liver, even if at very, very low levels. And the patients who had a positive serum HBV RNA quantification had higher cccDNA transcriptional activity in the liver. So as a summary, serum HBV RNA, yes, correlates with cccDNA transcriptional activity in both untreated and treated patients, but interpretation of the results may differ according to the assay that is used for the quantification, and the standardization is required. So to finish, I would like to show you this study where Gainey and colleagues analyze correlated antigen and serum HBV RNA with the Abbott test and the CHB phases in North American Hepatitis B Research Network adult cohort study in 1,400 patients, and they show the clear relationship between these markers and chronic hepatitis B phases, and both markers were also consistently correlated with the liver disease marker. However, limited additional value was found for correlated antigen serum HBV DNA in the differentiation of the chronic hepatitis B phases, which is not so surprising in my opinion, but they leave an open door for the fact that these markers could help with the classification of indeterminate patients, so those patients that we cannot really classify according to the classic guidelines. So from our side, we tested the Roche investigational assay in a cross-sectional study of a real-life prospective cohort of 1,500 chronic hepatitis B patients that were recruited in 5 clinical sites between France and Italy. We have nowadays more than 2,000 patients enrolled and almost 4,000 samples collected in a biobank. So these patients were mainly European and South Africa origin with the correspondent genotype distribution. And the results of the baseline results at inclusion of the first 1,500 patients show that we have most of the patients that are HB antigen negative and half of them which are under NUC treatment, and 25% of these patients couldn't be really classified into the classic CHP phases and were called intermediate viral load because they were HB antigen negative patients who had a higher viral load that couldn't be categorized as chronic infection. So similarly to what Gani has published, we have a clear relationship of the serum biomarkers with the phases and also a positive correlation with disease marker. And only the analysis of the follow-up with the sample will help us inform on the capacity of these markers to inform on phase transition and also response to treatment. But I wanted to leave you with a bit of provocative data, because when we have patients that are both positive for RNA and correlated antigen, the correlation between the two is very high in untreated patients, both HB antigen positive and negative, and very high in HB antigen positive NUC-treated patients, much lower in the HB antigen NUC-treated one, probably because the levels of these two markers reach the limit of detection. But 30% of the patients that we had in our cohort had discordant core and serum HBV RNA detection. Why? What is the meaning of that? So besides the fact that there are two different assays with two different limits of detection and detected two different things, I clearly believe that we have to go in this direction and understand which type of biological meaning could be under that. So to conclude, these two biomarkers are promising surrogate markers for cccDNA transcriptional activity. We have to go on inquiring their combination. So stop NUC studies have informed us the fact that these markers could help stratifying patients for the probability to achieve functional cure. And we still need knowledge from translational study, public intrahepatic and serum data. And also we have to pay attention to the fact that biomarkers have to be selected according to the therapeutic strategy. So if you want to know some more about these biomarkers and beyond, please go and have a look at the work that we published led by Anna Krimvis and Peter Ravel, which featured the November cover of Nature Reviews Gastroenterology and Hepatology. And thank you very much for your attention.
Thank you, Barbara. Very nice, very nice summary of a lot of data. We continue with our program, and it's my pleasure to call Michael Biermer up, who is, in addition to his past practice as a physician, and is now working at Janssen, and he will be telling us, answering a very difficult question. Does the CAM 6379 contribute to the antiviral activity of the siRNA 3989 in chronic hepatitis B? Lessons learned from the REEF1 and REEF2 studies. Michael.
Well, thank you very much, chairs. Before you go, thank you, Harry.
I'm not going.
Wanted to thank you for inviting us to present here at this excellent meeting. And we were asked if we could already give a lessons learned presentation, and I think we can. We have large database with and around 3989 from the two studies, REEF1 and REEF2. And on behalf of the study teams, we did a very close look into exactly the question, what is the contribution of 6379 to the antiviral activity of our siRNA 3989? These are my disclosures. I work for Janssen and J&J. And we had shown exactly this cartoon 3 years ago in this room when we were announcing the plans for the REEF1 study, the rollout of the REEF1 study, where everything was centered around the yellow cross that you see, the blocking of all viral transcripts with the siRNA 3989, but where we had obviously a red box, nucleoside analogs, and two blue mechanisms of actions for the capsid assembly modulator, 6379, and planning. And in particular, the further to the left, where we are expecting the blocking of replenishment of cccDNA, obviously was an interesting target and an interesting question, which then made it into the design of our phase 2b study, REEF-1. Just recently, we had the important paper on the nomenclature of the core assembly protein targeting antivirals, where we now classify the 6379 as a CAM-E. E stands for empty, whereas CAM-A would be for aberrant. We also talked about this one 3 years ago. So here, very quickly, preclinical data, AAV mouse model with HBV replication, where you clearly see to the left, HBV DNA had a additional effect of the combination, where you see in violet the lowest reduction was in the arm where 6379 and 3989 were combined. On S antigen, you see a clear differentiation between placebo or vehicle and the capsid assembly modulator alone for the two other arms, but the combination, the addition of 6379 to 3989 did not show much of a difference if this was tested in the mouse model. So everybody has seen the design of the REEF-1 study. I saved time here, only 10 minutes in total. Important, we were testing in different colors. 3989 alone, 3 shades of blue are the 3 different doses, 40, 100, and 200 milligram. And with 100 milligram 3989 in green, we also had a triple combination where we have 6379 in addition. A triple because all arms received the nuke. And then importantly, at week 48, only patients who qualified for stopping or met stopping criteria were allowed to stop the nuke, whereas other patients were continuing with the nuke. And that is important when we combine REEF-1 with REEF-2 a little later. Very important, REEF-1 had a wide population, E positives, E negatives, not treated, and virologically suppressed. And that is also different in REEF-2. I'll get back to that. So the first thing was our primary endpoint, proportion of patients meeting these stopping criteria based on ALT, DNA, E antigen, and S below 10. And you already see here in the middle blue bar, which is 100 milligram without 6379, and the green bar, which is with 6379. And there's a typo. It shouldn't be 200 milligram, 399 should be 100. Damn. So apologies for that. It is 100, very important. You have to believe me. And the original is also using this 100. So you see that there is a numerical difference, looking like blue is doing better than green. So the capsid assembly modulator not helping. And the same thing we have seen here in the reduction of S antigen over time. You again see a nice dose response. All blue is getting further down the higher the dose, from 40 to 100 and to 200. But the green arm, when we add 6379 to 100 milligram, is not showing a better response than the medium blue. It is showing little less. This was our observation in REEF-1, and is all discussed and published. So now we look into REEF-2. Why do we do so? Because we have, here it's correct on the slide now, we have one green arm in REEF-1 with 100 milligram triple, and we now can look at an arm from REEF-2 where we have 200 milligram with addition of 6379. And that's the purpose of the analysis today, where we are first looking at the baseline characteristics. I mentioned it's obviously not identical populations, and we enrolled REEF-2 only in Europe. We have a good proportion of Asian patients, but it is not a global study like REEF-1 was. I put a little red circles around important observations. Obviously, in REEF-2, we requested every patient was on the nuke for at least 2 years. In REEF-1, 6 months were good enough for the nuke-suppressed patients. And that may be reflected in the proportion of patients that are HBV RNA negative at entry and correlated antigen undetectable or lower limit of quantification at the entry into the study. You see that all arms in REEF-1 are having lower numbers in that, possibly reflecting that we are not comparing apples with apples here, but we are approximating, and that may be good enough for now. So what we did here, and this is new, data or a new look at this cross-study comparison, REEF1 and REEF2, we only included patients from REEF1 that were virologically suppressed and E negative at entry, and we see 4 lines here. First 2 comparisons on the 100 milligram we had already seen in REEF1, so this is now focusing on the E negative nuke suppressed patients in dotted lines, green being triple and light blue being dual with 100, and you see now the solid line coming from the REEF2 data, 200 milligram in triple, compared to the dotted line, dark blue is the lowest line here, where we have the dual arm from REEF1. And here you clearly see that there is, again, an impact of 6379 not to better, but rather to less good as reduction. We have done longitudinal PK/PD modeling, and this was actually kind of confirming that what we see here is within expectation, that we really see that with the addition of 6379, the S reduction is less good in response to 3989. Now I show you also first 24 weeks of follow-up. Next week you will see the complete follow-up of 48 weeks from Kosh Agarwal. So here you also observe what we discussed earlier in the morning, that in the REEF2 study we have a very flat off-treatment line, which is not only explained with the addition of 6379, because then we would also expect to see this flat line in the green arm in REEF1. So in REEF1, there were patients who stopped the nuke, but this is in the range of 10 to maximal 30% per arm, which is different from the REEF2. REEF2, every patient stopped the nuke at end of treatment, and I suppose we are mainly seeing this effect here as a reason for the long flat line. Very important, we have also looked at cutoffs, and you see here with the same color coding, REEF2 is the lowest and should be now compared to the third row where the 200 milligram REEF1. If you look at 100 milligram, it looks very, 100 units cut off, it looks very comparable at week 48, 80 versus 71. But if you look at less than 10 units and also less than 1 unit, there is a clear benefit for the dual arm from REEF1 over the triple arm from REEF2, with all caveats that come with this cross-study comparison. One possible explanation would be drug-drug interaction. Only a short slide here taken from an earlier presentation. If we compare the first with the second column, then we do 100 milligram dual versus triple. And if we look at third versus fourth column, it's 200 milligram dual versus triple. And I think you all agree there is absolutely nothing on the 2 triggers which are listed in the title of this slide, which is the composition of 3989. So very likely that we're not having a direct drug-drug interaction explaining the observation. It's also important, and now we go back to REEF1 only, that we have not seen the same effect or impact on E antigen levels. So here we look at the currently not treated patients to the left versus nuke-suppressed patients to the right. The lines are kind of all over. There's no clear inhibiting effect on E antigen. And before I close with 12 seconds left, I also wanted to show quickly lines for EGFR on treatment and off treatment, which was kind of puzzling us. We had a strong reduction of EGFR in both arms in REEF1 that contained 6379, with a very stable reduction on treatment and a very fast increase after end of treatment. And that was now also seen in the REEF2 study, something where we would clearly say this pattern looks more like a transporter interaction in the elimination of creatinine. All this observation only if we calculated EGFR based on creatinine, and much less so, if at all, if we looked at cystatin C in more recent studies. I don't have time for my summary, but I hope my presentation was clear. So this is for the record. Conclusion is that, as you all know, we made, based on this decision in September 21, the decision to pull out 6379 from planned, but also from ongoing studies. So we have a couple of studies that are still running, and where patients halfway through were then stopping 6379, not for safety, but certainly for this observation of potentially less effectiveness. And that is maybe the most important conclusion for my little presentation. Thank you very much.
So the next speaker is Emily Tai. She is a Senior Director of Immunobiology at Biomarker Research at Arbutus. She will give her presentation online, and she will talk about evidence of T-cell restoration after siRNA therapy, is a work that we already referred to, many of us, this morning. So now we will have the real stuff from the real author.
Thank you. Hi. So thank you, everyone, and thanks to the organizers for inviting me to speak today. And I do apologize for not being able to attend in person. So hopefully I'll see some of you at AASLD. So on behalf of my colleagues and external investigators, I'd like to present to you our key findings regarding evidence of T-cell restoration after siRNA therapy. So these are my disclosures. So as has been discussed previously and earlier today, there has been described an association between HBs antigen levels and treatment response. In the literature, as well as emerging data from early phase clinical trials, it's been indicated that low baseline levels and rapid decreases in S antigen levels has been associated with better responses in patients that have been treated with PEG interferon, nucleoside analogs, checkpoint inhibitors, and therapeutic vaccines. So in addition, which has discussed earlier, in patients stopping treatment, low S antigen and or undetectable HB4-related antigen at the end of treatment has also been associated with a greater probability of S antigen loss. So how we interpret HBV-specific T-cell responsiveness is complicated. There are multiple factors that may play a role. Certainly age has been indicated in previous publications. And in addition, I think a lot of the data has been hampered by the fact that it is very difficult to assess liver versus peripheral compartments, so T-cell responses in each of those compartments. What is also unknown is whether the rapid declines in S antigen and other antigens that we see mediated by RNAi treatment may elicit responses that are distinct from naturally low S antigen. And this is something that Jordan touched upon earlier today. So just as a reminder to everyone, AB729 is a novel GalNAc conjugated siRNA therapeutic, which targets all HBV RNA, leading to the reduction of HBV antigens, including S antigen. AB729 is currently in phase 2 development for the treatment of chronic hepatitis B in combination with other agents. So the data that I'll be describing to you today comes from a phase 1 study examining the safety and pharmacodynamics of single and repeat doses of AB729, healthy subjects, and CHB subjects. So CHB subjects in part 3 were dosed with AB729 for 24 weeks with the option to extend treatment to continue through week 48. At least 24 weeks post the last dose of AB729, subjects were also given the option to discontinue new treatment if they met the following eligibility criteria: ALT less than 2 times upper limit of normal, undetectable HBV DNA, subjects had to be E antigen negative, and S antigen had to be less than 100 IU/ml at 2 consecutive visits. So we conducted today immunological assessments looking to see if there was an impact of AB729 dosing on HBV-specific T-cell activation markers. And these were done in subjects who were undergoing repeat dosing of AB729 at 60 milligrams either every 4 weeks or every 8 weeks. We collected longitudinal PBMC samples in a subset of these subjects and conducted ex vivo HBV-specific T-cell interferon gamma fluorescence plot, T-cell proliferation assays, as well as immunophenotyping by flow cytometry. Looking at the baseline characteristics of the two cohorts that I'll be describing today, we see that they are very similar in terms of age, gender ratios, Cohort E, which was every 4-week dosing cohort, was predominantly white. Cohort F, which was the every 8-week dosing cohort, was predominantly Asian. And both cohorts had very similar ALT as well as S antigen levels at baseline. So looking at the HBV-specific T-cell activation markers, and I know this data has been shown earlier today, but I'll go through it again as well. So I'll just to orientate everyone, in these overlay graphs, the S antigen in each subject is indicated by the blue lines. Brown bars indicate HBV-specific interferon gamma production, and the purple lines are the stimulation index for HBV-specific T-cell proliferation. In the 7 out of 7 subjects that we've profiled to date, we see upregulation of HBV-specific T-cell interferon gamma production, indicated here. Looking at ALT, in some of these subjects, those increases in HBV-specific T-cell interferon gamma production was associated with mild to moderate ALT elevations. And the timing of those ALT elevations occurred either preceding, as in this subject here, the interferon gamma production, HBV-specific T-cell interferon gamma production, or occurred interferon gamma production, or occurred concomitantly with that increase in HBV-specific T-cell interferon gamma production, as illustrated by the subject here. It's important to note that these increases in mild to moderate ALT were not associated with increases in other liver safety markers and were not deemed adverse by investigators. If we examine the profiles of these HBV-specific T-cell interferon gamma responses more carefully, we see 2 patterns emerge. 5 subjects displayed an increase in HBV-specific interferon gamma responses that occurred between weeks 12 and 36, so coinciding with the nadir of S antigen decline, as illustrated here. And 2 subjects had increases in HBV-specific interferon gamma production occurring after stopping of AB79 dosing, so completion of AB79 dosing, as illustrated in these 2 subjects here. This is another way of looking at the HBV-specific T-cell interferon gamma responses. So in this graph here, you can see that the data are presented as the fold increase over the pre-dose baseline levels for each subject. And I think, as you can see here, there are 2 clear patterns emerging. One is that, again, as I mentioned before, we see elevations in HBV-specific T-cell interferon gamma responses occurring on treatment. And in those 2 subjects, we also see increases happening off treatment, so after completion of AB79 dosing. So we also conducted immunophenotyping of global CD8 T cells in this study, gating for markers of exhaustion as well as effector function, as indicated here. In 4 out of 6 subjects, the frequency of the exhausted CD8 T cells was found to have declined by end of treatment, and also up to 12 to 16 weeks of follow-up, which was the last time point that we had assessed. No obvious trend was seen with exhausted or effector CD8 T cells. Looking at clinical outcomes of the subjects that we've profiled to date, and separating them based on whether they were dosed with AB79 every 4 weeks or every 8 weeks. In the every 4-week cohort, we observed that subject 41, which is indicated by this blue line, teal line here for S antigen, seroconverted and became S antigen less than LAQ at week 84, which was 40 weeks after the last dose of AB79. This subject remained on nucleoside analog treatment after completing AB79 treatment. The remaining 4 subjects, as indicated here, did not meet the predefined nucleoside analog discontinuation criteria that I described earlier. In the every 8-week dosing cohort, of the 2 subjects for whom we had PBMC samples available, 1 subject, subject 53, did meet the predefined nucleoside analog discontinuation criteria and did elect to stop nucleoside analog treatment. The other subject did not meet this criteria. Further data, including extended follow-up of subjects who have completed AB79 dosing and stopped nucleoside analog treatment, will be presented at AASLD, and this data that will be presented will also provide further support for immunological control in these subjects. So in summary, in CHP subjects that we have profiled to date, AB729-mediated S antigen reduction is associated with increased HBV-specific T-cell activation, we do observe a decline in exhausted CD8 T cells at the end of treatment, and this appears to be durable. We do see that it's still present at 12 to 16 weeks after follow-up. And the limited data thus far does suggest that there is an increase in HBV-specific T-cell activation occurring at the nadir of antigen reduction, which may be beneficial to clinical outcomes. We are currently profiling larger numbers of subjects with an interest to explore whether these increases in HBV-specific T-cell activation markers occurring during AB729 dosing are linked or associated with clinical outcomes. The results also suggest that the effects of AB729 treatment may be enhanced further by combination with immunomodulatory agents. So I'd like to acknowledge my colleagues at Arbutus BioPharma, as well as the patients and study investigators who are participating in the AB729-001 study, and for whom, without whom this data would not be available. And I thank you for your attention, and I'd be happy to address any questions.
Well, Emily wins the prize for keeping exactly on time. She finished as it went from 1 second to 0, so well done. Thank you for that very interesting presentation. And we're going to move on with the program to ALT and virologic profiles in Bepi responders versus non-responders. And this will be Stuart Kendrick, who is presenting from GSK. And a pleasure to have you here.
Thank you very much, Jordan. Thanks also to Adam, Harry, and the organising committee for the invitation to present at this very exciting meeting that moves the field forward. I think we've noticed a pattern to the invitations here, which is that when we have data that has us scratching our heads and bothering us and trying to work out how to make sense of it, we then get an invitation to come and explain it to this meeting. So I'm looking forward to your help with ALT virological profiles in Bepi responders and non-responders. In terms of declarations, I'm fortunate to work at GSK, which is a very exciting place to do hepatology research at the moment. GSK funded and designed the data collection that we're sharing today, and we're very grateful to the investigators, the patients, the advisors, and the GSK study teams for all their commitment. So I think I'll start by introducing bepirovirsen, or Bepi, which is our unconjugated antisense oligonucleotide, and talk a little bit about its mechanism, because that might help us to guide our discussion and our interpretation of the effects on hepatitis B surface antigen and ALT flares, and perhaps give us some ideas about why that might differ from treatment with a small interfering RNA. So Bepi is a single-stranded antisense oligonucleotide. It's made up of a central portion of RNA with DNA on either side. It's given by a subcutaneous injection just in normal saline, and once it enters the cell, it's active in the cytoplasm and in the nucleus, and it directly binds on to hepatitis B RNA transcripts. It binds with sequence specificity to a transcript, to a site that's common to all hepatitis B RNA transcripts, and it binds either with exact sequence homology or if there's one mismatch. The sequence that's chosen is very well conserved and has a low mutation rate. And once it's bound, it attracts an intracellular enzyme, RNase H. The RNase H initiates the breakdown of the RNA, and after one or a few cycles of this, it also dissolves the Bepi. So that's why Bepi needs to be dosed on a weekly basis, and also why we designed the studies with a loading dose. It reduces hepatitis B RNAs, including the pregenomic RNA, leading to reduction in viral replication and serum antigens. And that's in contrast to a small interfering RNA, which is an RNA duplex administered by injection, but usually in a more complex carrier. It enters the cell and is active in the cytoplasm by activating the RISC complex, which then stays active for a period of time, destroying multiple copies of messenger RNA, and so is dosed less frequently. The other important thing about Bepi is it's an unconjugated molecule, so it doesn't have GalNAc that targets it to hepatocytes. And that means that it has a different distribution from the GalNAc conjugated molecules. It is distributed not only to hepatocytes, but also to non-parenchymal cells in the liver, including epithelial cells and inflammatory cells. And one of the things about Bepi is that we did take both the conjugated and the unconjugated molecule into the clinic in proof of concept studies, and actually saw that we had a different effect with the two molecules. The conjugated molecule didn't have as profound an effect on surface antigen reduction and didn't show ALT reductions. Interestingly, we've also got more recent evidence, which has been presented at recent meetings, that Bepi can have an additional effect in those non-parenchymal cells, which is of innate immune stimulation, probably through toll-like receptor 8, and that's been presented in terms of human clinical data on cytokine profiles, but also in model systems showing specificity for human TLR8. So we first got a sense of these reductions in surface antigen and ALT flares, which occurred either preceding which were either preceded by or occurred simultaneously with surface antigen reduction in our small phase 2A study. At the 300 milligram dose, this was in 16 patients, of which 12 were not on nucleoside analogues, and they were treated for a 4-week period with weekly dosing plus additional loading doses in the first 2 weeks. And you can see from this panel that we saw reductions in surface antigen in the upper panel, and patients divided into responders in green and non-responders in red. And we also saw ALT elevations, which occur predominantly in the green patients, without ALT elevations in the non-responders. If we look at some individual patient profiles, one from a treatment-naive patient, one from a nucleoside analog treated patient, you can see that the surface antigen decrease occurs rapidly during the 4-week treatment period and is followed by an ALT elevation. In the treatment-naive patient, this was quite a significant elevation, I think up to around 800. Importantly, all the ALT flares were transient and self-resolved. They tended to occur between 4 and 8 weeks after the start of treatment, and consequently they occurred around the time that the Bepi was discontinued. And importantly, there was no increase in total bilirubin or other markers of liver dysfunction. Looking at this in a little more detail in this small proof of concept study, the ALT flare does appear to be associated with the magnitude of the surface antigen reduction. In the left-hand panel, you can see the study participants who received either placebo, 150 or 300 milligrams. These were all hepatitis B positive patients in this left-hand panel. The blue ones are the nucleoside analog naive, and the orange ones are the nuke-treated patients. The placebo ones are all at the top, and then the others are divided up according to their surface antigen decline, with the upper group being those who achieved at least a 2-log decrease, and then the lower group being those who didn't even achieve a 0.2 log decrease. And what we can see is that there was no ALT flare in those who did not have a meaningful surface antigen decline. And then if you look in the right-hand panel, you can see this divided by dose, suggesting that in Hep B positive individuals, there appears to be a dose relationship with the area under the ALT curve. However, in the green dots are the healthy volunteers who were Hep B negative, who were dosed up to 450 milligrams and didn't really show any movement in ALT at all. So this appears to be a phenomenon in Hep B positive people. There was one patient, the one marked with the star in the left-hand figure, who achieved a significant surface antigen decline without an ALT flare. So perhaps the two are not necessary for reduction. And we did start to explore the relationship between surface antigen and ALT flares with immune cytokines and chemokines in this study. I'm not going to discuss this in detail, but you can see that there was a pattern of increase in serum cytokines and chemokines greater in the surface antigen responders than in the non-responders, and greater in those with ALT flare compared to those who didn't, with the pattern suggesting activation of innate immune responses with the potential to activate adaptive immunity. So after this small phase 2A study, we had two big questions around the ALT flares. So were these flares associated with viral antigen reduction, or were they associated with stopping Bepi treatment? And secondly, if we treated for longer, would the ALT flare persist, or would it stop? And so we were able to address these in BClear. This is our phase 2B study, which has completed. It featured two cohorts of patients, one on stable nucleoside analog treatment and one naive cohort. There were around 230 patients in each cohort. They were stratified for e antigen and surface antigen, and randomized to 4 groups: Bepi 300 milligrams for 24 weeks with a loading dose, then 12 weeks stepping down to 150 milligrams, then 12 weeks alone, and then a group that started on placebo and then went on to 300 milligrams without a loading dose. The primary endpoint was undetectable surface antigen and unquantifiable DNA 24 weeks after the end of treatment. That's marked by the blue stars, and those are data which MFUN is going to present in 6 days' time in Washington, D.C., so I'm going to steer clear of those and not steal his thunder. The black triangles mark the end of treatment response, which were shared at the EASL meeting this year, and they give us the opportunity to look at the relationship between ALT flare in this study and surface antigen decline. At that end of treatment point, up to 28% of participants achieved undetectable surface antigen, illustrated here in the Arm 1 group of the on-nucleoside analog treatment group. And we saw that the ALT flare remained transient even with longer Bepi treatment. Here you've got 2 example traces, the one on the left from an on-nucleoside analog e antigen positive patient. You can see a decline in surface antigen and e antigen, along with the emergence of e antibody, followed by an ALT spike. And then on the right-hand side, you can see a not on nuke patient, again showing a decline in surface antigen and a decline in DNA, again with a larger ALT spike. Of the 457 patients in the study, 132 of them displayed an ALT flare greater than 3 times the upper limit of normal, and the vast majority of those ALT flares were associated with a significant surface antigen decline. So this suggests that if you have an ALT flare, it's very likely that it's associated with surface antigen reduction. However, does the converse also apply? If you have surface antigen reduction, do you have an ALT flare? And the answer to that is it probably depends a little bit on how you define a flare, but probably not. So if we define a flare as 3 times the upper limit of normal, you can see that we did occasionally see patients like the left-hand one here, where there is a decline in surface antigen, but really you'd have to have a very strong eye of faith to say that the ALT went up at that point. But those participants were extremely rare. What we actually saw more of was like the right-hand panel, where there is a bump in ALT associated with the decline in surface antigen, but not a bump large enough to really define itself as a flare. So in summary, surface antigen clearance was observed following 12 and 24 weeks of Bepi in the BClear study. The ALT flares, defined as 3 times upper limit of normal, were observed around 4 to 10 weeks of treatment. They were associated with surface antigen response in the majority of participants, but some participants had a surface antigen response without or with only a limited ALT increase. The end of study data will be presented at AASLD. I think it's important to note that this analysis focused on the association between flares and the virological endpoints. I promised Jordan I won't do hand waving, and I'd say that ALT equals a restoration of adaptive immunity, but I do think it's important to study this. The BFINE study is ongoing. It's a mechanistic study with fine needle aspirates that should provide some information on the immunological changes that are occurring in the liver during flares and during surface antigen clearance. And then there are also ongoing studies which will investigate the role of immune modulation after Bepi treatment, and these are B together with pegylated interferon and a study using our therapeutic vaccine, which we now call CHB targeted immunotherapy. Thanks.
And the next speaker is Grace Wang, Vice President of Clinical Development at Assembly Biosciences, that will present us the development of next-generation core inhibitors at Assembly.
Thank you, Massimo, and thanks for the organizer for the invitation. I'm here actually to present the Assembly development progress for the next generation of core inhibitors. As we know, a number of core inhibitors are in clinical development for the treatment of chronic hepatitis B virus infection, and these agents have the potential to interfere with separate and distinct steps in the HBV life cycle than currently approved agents, specifically interference with number one, pgRNA encapsulation and DNA replication. Number two, capsid deassembly and cccDNA formation. While first generation of the agents interfere with the first step, they have lower potency against the second step. Assembly Biosciences' next generation core inhibitors are optimized against both mechanism, the viral DNA replication, and the cccDNA formation. So what is needed in order to further improve antiviral activity of core inhibitors? First, we need to ensure the pharmacology of those agents to deliver sustained therapeutic concentrations and ensure adequate target coverage against each mechanism. Next, increasing the potency against pgRNA encapsulation, DNA replication, capsid deassembly, most importantly, to introduce additional mechanisms associated with the cccDNA interference. Of course, we need an agent with favorable clinical safety profile. So Assembly is currently developing two next-generation HBV core inhibitors with attributes we believe will make significant progress in core inhibitor optimization. These two core inhibitors are 3733, we call it ABIH 3733, and ABI 4334. A summary of the potency of those two agents were recently presented at HBV International Meeting in Paris in September. This slide summarizes these newer and structurally differentiated agents against relative to the first generation of the core inhibitor, vebicorvir. So with these incremented improvements in potency against the key mechanism, particularly cccDNA formation, we anticipate improved virologic outcomes in hepatitis B virus patients. The next slides, I will review the development status of those two agents. Of these two agents, ABIH 3733 is furthest along in development, having completed a phase 1A study in healthy subjects. This was reported at AASLD 2021. In this study, single ascending doses of 100 milligrams, 250 milligrams, and 500 milligrams were assessed, as well as 250 milligrams for 5 days. These were administered as liquid formulation. A fifth cohort subsequently received an initial prototype of tablet formation at 300 milligrams. This slide summarizes observed adverse events and the lab abnormalities observed in the study. Overall treatment were well tolerated with AEs of grade 1 and lab abnormalities of grade 1 or 2. No increase in ALT observed. In this study with multiple dosing with liquid formulation, we were able to achieve the exposure coverage for inhibition of HBV DNA replication and prevention of cccDNA formation. The initial prototype of tablet formulation resulted in reduced bioavailability. Subsequently, formulation modifications were made. This was presented at EASL 2022. And this improved tablet formulation is now being assessed in an ongoing phase 1b study in hepatitis B patients. As I mentioned before, a phase 1b study with 3733 is ongoing now. The study is assessing 28 days of treatment with 3733 versus placebo in e-antigen positive or e-antigen negative patients. The overall study design is presented here. It is anticipated that the initial data will be communicated by the end of this year. Also, we are currently undergoing the startup activities in 4334 1A study in healthy subjects. The overall study design is presented here, and the first part of this study is a single ascending dose cohort evaluation, and followed by the multiple dose ascending cohort evaluation for 8 days. We are also planning to evaluate food effect in this study. We are anticipating the first subjects will be receiving the 4334 by the end of this year. As summary, we are moving forward with the development of the next generation of the core inhibitors, and with the improved incremental potency of those two agents on the key mechanisms, especially for cccDNA interference, we anticipate improved virologic outcomes in our patients. With that, I would like to thank our study participants and their families, and also thank our study participating investigators and the staff. Without them, we will not be able to obtain any data. Thank you.
Thank you, Grace. And we move on to the last talk of the session. I'm going to call upon John Flaherty from Gilead to talk about bulevirtide data from real-world usage after approval in Europe.
Thank you. Good afternoon. I want to thank Adam and Harry for the invitation, and thank you for your attention today. I'm happy to talk about real-world data with bulevirtide, and the caveat here, of course, is these are not Gilead-sponsored studies, but one would hope that the data generated in the real world would align with the studies that are being done for registration. These are my disclosures. So what I'd like to do today is briefly review the current approval status for bulevirtide, and then, because of the time limit, really focus on some representative real-world studies and give sort of a top-level overview of the data and how these compare with ongoing clinical trials with bulevirtide. And of course, we need to point out along the way the strengths and limitations of this sort of comparison. We all know that bulevirtide is a first-in-class entry inhibitor for treatment of chronic Delta virus infection. Specifically, it's a linear polypeptide that is chemically synthesized. It binds to NTCP directly and thereby blocks entry of hepatitis D virus and also hepatitis B virus into hepatocytes. In July of 2020, bulevirtide was approved as HBcrAg by the European Medicines Agency. for the treatment of chronic HDV infection. This was a conditional approval, which was based on data from 2 small phase 2 studies, MIR 202 and MIR 203. The agency in Europe knew at the time that there were additional studies ongoing, a phase 3 study, MIR 301, and a phase 2b study focused on finite treatment, MIR 204. And those studies are still ongoing, will read out shortly. This is the indication and posology in the SMPC in Europe. It's indicated for the treatment of chronic hepatitis delta virus infection in serum or plasma positive HDV RNA positive patients with compensated liver disease. I should point out bulevirtide must be given by subcutaneous injection. The dose is 2 milligrams given once daily, and it's indicated to be given as monotherapy or in combination with nuke analogs for treatment of underlying HBV infection. So the label is silent on use in combination with interferon. And then lastly, the optimal treatment duration is unknown, and treatment should be continued as long as it's associated with a clinical benefit. Sort of a nebulous statement, but we can't argue that that is true. It's just the specifics around that are difficult to know. So what I'd like to focus on today is the use of bulevirtide for chronic suppressive treatment at the 2 milligram dose level. In his background, the MIR 202 study looked at ascending doses of bulevirtide at 2, 5, and 10 milligrams compared to a control of TDF, and all groups received also concomitant TDF for underlying HBV infection. And in this study, the endpoint at 24 weeks, the on-treatment endpoint, evaluated virologic response, which is a standard definition, more or less, of 2 log decline in HDV RNA level or undetectable HDV RNA level. Also, secondary endpoints in the study were ALT normalization and the so-called combined response, which is ALT normalization and the virologic response. And you can see the results here. Virologic response was achieved in over 50% of participants, and there was no clear dose effect seen. The combined response also was similar between the treatment groups, and ALT normalization was seen early in week 24 in about half of the patients in the study. And after discontinuing 24 weeks of treatment, rebound occurred in nearly all patients. I should also point out this data is now published in the Lancet Infectious Disease Journal with Heiner Wiedemeyer as the lead author on that. Now, really the gold standard for chronic treatment is our MIR 301 study, a phase 3 study where patients are randomized 1:1:1 to either 2 milligrams or 10 milligrams of bulevirtide compared to delayed treatment. The primary endpoint results at week 48 were presented at EASL this year by Heiner Wiedemeyer, marvelously, I might add. And in this analysis, we also did a pre-specified alpha-controlled week 24 analysis, which was presented earlier. The study will continue treatment through 3 years, or week 144, followed by an off-treatment period. So using this as a backdrop, I think we can look now at some of the real-world data. And to put that in context, these are the results that were presented for MIR 301. The primary endpoint, combined response, was achieved by similar proportions in the 2 and 10 milligram group, and similarly, a higher proportion achieved virologic response, and over half achieved ALT normalization at week 48. So these data do support the label for 2 milligrams once a day by sub-Q injection and have been submitted to EMA and are currently under review, but not yet in the European label. I should point out also that not unexpectedly, because of its mechanism of action, elevated serum bile acids are seen with bulevirtide treatment, as we can see here from the 301 study. These are dose dependent, they occur early, and the mean levels are relatively stable over the treatment period. Would also like to point out at baseline that in all treatment groups, the bile acid levels were above the upper limit of normal, which is 10 micromole per liter, and those levels remained at or above the upper limit of normal in the control group through 48 weeks. Now, if you really want to dig deep into the data, I would recommend this recent publication, and it's not because Pietro is sitting here in front of us, but this is really an excellent review recently published in Journal of Hepatology, looking at the clinical data to date for bulevirtide given alone or in combination with pegylated interferon, and also includes a very nice overview of all of the real-world data to date. And I will also point you to the fact that at ASLD coming up, there are a number of cohorts that will have updated data that will be presented, some of which, including Pietro's Italian cohort, will be part of the late breaker presentation on Tuesday morning. So looking at the 24-week data collectively across some of the major cohorts in Europe, the light blue is the 24-week data from the MIR-301 study. For reference, you can see we've broken it down by virologic response, ALT normalization, the combined response, and also in this analysis we included undetectable to show that it doesn't occur very often at 24 weeks. And the cohorts included are the Italian cohort, the French cohort, which is one of the largest cohorts that's ongoing, and the German cohort. So at 24 weeks, the data appear, again, with the caveat of not doing cross-study, all the limitations of cross-study comparisons, that the data are generally consistent across cohorts compared to the controlled trial. And I think this is important because these, most of these patients in these ongoing cohorts had an urgent need for bulevirtides. They tend to be more advanced in their disease, the majority of which have compensated cirrhosis and advanced fibrosis. Moving to week 48 responses, these are the data comparing the cohorts in Italy, France, actually 2 French cohorts that have been ongoing, as well as a German cohort, comparing those 2 results at week 48 in MIR-301, again in the light blue on the far left. And the takeaway message here is that these cohorts through at 48 weeks seem to be generating similar response rates to what we see in the controlled study. And that's, I think, important information to take to heart. Just to move on now, I don't know how much time I have left, a minute left, just a couple of examples of this. This is the French cohort that will be updated at this year's ASLD meeting, but this cohort looks at a group of patients receiving bulevirtide alone and those receiving it with pegylated interferon, which is not a randomized analysis, but rather the physician preference. And you can see the characteristics of the group here with a very high baseline viral load in this population. And looking at their response rates over this 12-month period of time by a per protocol analysis, you can see in the dark blue, green that the response rates for the combined response are generally comparable to what we saw in the 301 study with very good safety and tolerability. And then lastly, I will mention the Italian cohort. This is published these are patients with advanced cirrhosis and clinically significant portal hypertension. It's a cohort of 18 well-characterized patients, and the response rates are really quite remarkable. And this paper is really worth looking at, and I think an update of this was also presented at Delta Cure, if I'm not mistaken. So very exciting and very important data coming from these cohorts. So these are my conclusions. I think it's pretty clear that the need for these cohorts remains, and we look forward to seeing longer-term data as we also will be generating longer-term data with bulevirtide in the ongoing program. Thank you very much.
So now there is a change in the program. We will not have the discussion now, but we will accumulate the discussion of this session and the global discussion that was planned for the end of the day. And I call Adam Gehring, our meeting co-organizer, to give us the ASLD preview.
All right, thanks, Massimo.
We'll start now and finish on Sunday.
Yeah, I regret offering to do this. It was a lot more work than I anticipated, and everybody's done a very careful job to try to protect their presentations at ASLD. But spoiler alert, these abstracts are available ahead of the meeting, and so, I mean, obviously, going through a preview, I can't give you in-depth details, but I just want to kind of show you what I think is going to be particularly interesting coming up the meeting. And given the time, I could only choose about 20 or 22 maybe abstracts to kind of focus on. So, I mean, I kind of separated these into, and I will say that not all of them have data, right? So some of it's just summaries, and I think it will help with the discussion that we're going to have afterwards. So going through these, I've kind of separated them by where I think they fit in, and so there was a few abstracts that were particularly relevant for functional cure. And it's on the screen up there, yeah, okay. And I think some of these come around the oligo-based drugs that we've been talking about extensively today, the ASOs and the siRNAs, and how is genotype variation and mutations and variants going to actually impact the efficacy of these drugs. And so in this case, this was a study also supported, I think GSK was part of, looking at an RNA launch sort of in vitro system where they can transfect in the pregenomic RNA and understand how nucleotide polymorphisms are actually impacting the efficacy of the ASO. And just kind of skipping through each of these fairly quickly, when you look under the results tab here, the abstract at least indicates that the central 10 nucleotides are under selection pressure, and this can actually impact the susceptibility to bepirovirsen compared to the wild type if there's a mismatch. So there is an impact on the antiviral efficacy potentially in the in vitro system. And then there is a study here from Janssen looking at their REEF1 patients, and they sequenced the RNA from baseline samples and compared the RNA sequences to the siRNA triggers for X and S. And here they found at baseline in the two cohorts, either 11% or 14% of the patients had one or more nucleotide polymorphisms, but they didn't see an apparent impact of the polymorphisms on the HBs antigen reduction. So indicates that these polymorphisms, we have to recognize are there, we know they were going to be there, and really understand how they're going to impact the efficacy. In this case, with the two-trigger system, it didn't seem to impact it. And then I touched on some of these abstracts before, but these are a couple of abstracts. The next two are functional cure patients. And in this study here, they used biopsy samples and actually stained for S antigen in biopsies from 52 functionally cured patients. And sort of the takeaway for this is that S antigen was actually detectable in 21% of the functionally cured patients. So there's clearly still transcriptional activity, and likely HBV integration contributes to that residual HBs antigen. And I think that is highlighted in the next study, which I also mentioned this morning, is a study using the Abbott immune complex assay. And so in this case, they took functional cure patients, used the Abbott assay, and I can't see how many are there with it anyways, the follow-up. But anyways, what they found was in the follow-up of these functional cure patients, in the gray here, and the gray shaded regions of the graph are after functional cure, and the x-axis are years in this case, and the dark black line at the top, let's see if I can get it up here. Nope. Oh, that's fast. All right, anyway. The dark black line are the immune complexes, and if you can't read the x-axis, some of these are up to 24 years. Many of them are multi-year follow-up. And so this kind of gets to the point that potentially the hypothesis that Georg presented earlier as well. And so I think there's going to be some interesting, and they've been alluded to already, some interesting long-term follow-ups to some of the data that we've seen today, and I think could frame our discussion here before. And this is the Bepi follow-up, and these data were taken from the abstracts. So these are in the abstracts for ASLD. These are the 24-week from Bepi, and if you look at the 6-month or week 24 follow-up there at the peak in the middle of the graph, you see the orange is the highest response rate, and this is their 300 milligram patients for 24 weeks. Unfortunately, that response starts to erode, and you can start to see that come down. And they've got two abstracts, and you can't, and then, sorry, I should point out the abstract numbers, or the talk numbers, are in the top left here. They have a huge amount of data on these, like a lot of these studies I'm not going to be able to cover, but this is definitely one to look at, because even though you see this go down, the stringent endpoints for this are, I think, require some more, a lot more detail than what I can present here. And then there's also a longer-term follow-up from the REEF-2 study, and this is the quadruple treatment from Janssen with the siRNA. Well, some of them now, the CAM has been removed, but the NRTI and I thought this was PEG. Oh, sorry, this was another one. Maybe I forgot. Forgot the PEG. Anyways, and so these are the 48-week follow-up after patients have actually stopped all antiviral therapy, and you can see here in the quick results that, you know, even though no patients achieved HBs antigen loss, the responses after 48 weeks were relatively durable. I mean, dropping only a little bit in the follow-up week 48 for the 100 units per mil, and 100 international units of HBs antigen. The same for those patients that get down to less than 10 international units. And again, there's a lot more detail in this abstract that I don't have time to, but it's definitely worth checking out at the meeting. And here is a study that Arbutus alluded to in their presentation, and this is follow-up data from patients that underwent AB729 siRNA therapy, and then these were an e-antigen positive cohort that stopped antiviral therapy. And so here there was a lot of interesting profiles because they have each of the individual patients in the poster. And I think one of the key points here is there was no ALT flares observed after stopping therapy, and this comes back to a comment that I presented earlier, and is the idea of stopping after siRNA therapy is clearly much different than stopping after the nukes. And then there's a bunch of new studies that are adding clinical trial data to the field, and here this is the one, the penguin study that I was mentioning from Janssen, where this is a quadruple combination with the siRNA, the CAM, the nuke, and the PEG interferon. And here, this is a add-on therapy with PEG interferon, where the patients start the first 3. And you can see here at the bottom right, the response really at 24 weeks is quite robust. I mean, it's really 90% of the patients achieve less than 100 units per mil of HBs antigen. And almost half of the patients get down to less than 10 international units. And again, there's a lot more data here, but I think this kind of study reiterates how well the field is doing about driving these antigens down within this 24-week treatment window with multiple different strategies now able to achieve really significant declines in viral parameters within the 24-week period. And then there is an additional study from Arbutus that is going to be presented, and this is a combination of Vabicavir, their CAM, with the siRNA. And I put this one up here because it's, in this case, the blue line is the VBR alone with nukes, and then the other 2 lines, one is the siRNA and the other one is the siRNA with the CAM. And in this case, there doesn't really seem to be any competition between the mechanisms of action, so it'll be interesting to know or understand what the difference here is in terms of this combination that seemed to be somewhat antagonistic in the Janssen studies. And then the next 3 studies, Vir is quite prolific at the meeting, and Andre presented some of this a little bit ago, but they have actually 3 studies that are going to be presented. And this study here is their siRNA, VIR-2218, along with their anti-HBs. And I think this is quite striking to see the different kinetics in a study like this, where the siRNA is the blue line along the top, and you add the VIR-3434 there at week 17, you see this enormous drop in S antigen, whereas the lead-in and the combination here with the other 2, the red and the green lines, show that fast reduction in S antigen and then the taking over from the siRNA. They also have the siRNA in combination with PEG interferon, and this wasn't shown up there earlier, but basically this is a complicated dosing regimen, and again, I won't go into the details here, but they added interferon on for different periods of time, and ultimately the patients that received a little bit longer interferon had more durable responses in combination with the 2218 siRNA, and some patients in this trial actually lost surface antigen. And then again, the last study that is going to be presented from Vir at ASLD was the viremic study. And I think this was important. It shows that it's not just the subviral particles that are being eliminated from the peripheral blood, but in the dotted lines here, you can see also a decrease in the HBV DNA from the peripheral blood in the presence of the Vir3434 monoclonal antibody. Another one that is being presented is another monoclonal antibody, this HH03. And unlike the Vir monoclonal antibody, this is a pre-S1 targeting antibody. So theoretically, you're going to get mainly the viral particles in this case. And here it was a phase 1 study with 67 patients in a single ascending dose. Well, actually, no, 3 doses here of increased in terms of the monoclonal antibody treatment. And you can see the data here on the right side of the screen, looking at S antigen decline in their 20 milligram per kilogram group. It's clearly a little bit slower. We're looking at like 6 to 8 weeks in this treatment window here. And that's likely because of the pre-S1 targeting aspect of this, but ultimately found this antibody was safe and it had some antiviral activity in the plasma. And then also alluded to in Stuart's talk was the GSK therapeutic vaccine, and they have a nice poster on this. This is an interesting new vaccine that's coming down the pipeline. It's actually a 3-component vaccine that's made up of a chimpanzee adenoviral vector, a modified vaccinia ankara vector, as well as their AS01 adjuvant in combination with recombinant proteins. And in this case, they're showing the first 2 of a 4-dose regimen in the poster, where they're either comparing the viral vector prime boost strategy on CD8 T cells or the AS01 recombinant protein effect on CD4 T cells. And the data for CD8 T cells is in the top, these sort of purple graphs here. And I can see after the first couple of doses that the magnitude of the CD8 T cell goes up and the number of patients with their CD8 T cell response goes up. The CD4 T cell response was a little less robust in this case. Only one of the patients had an ASO response to the, a surface antigen response. More of them had a core response. But again, this is only 2 doses of their 4-dose regimen. So I think that there's going to be more mix and match strategy, as you can see in the dosing schedule on the bottom left. And then I put this in there just because of the sheer number of patients. This is the Everest project. This is a multi-center real-world study in China where they basically gave inactive carriers, 20,000 of them, interferon, and looked at the outcomes of treatment. And they found 3,472 patients achieve functional cure. And maybe not totally surprising, the longer they took the interferon, the higher the response rates were. Particularly at 48 weeks, they're up to about a 33% functional cure response. And then just in my last minute and a half, I know it's the tour de force here, but there's a lot of preclinical data, and I actually cut out about 8 slides of this, so I'll spare you all. But I think another aspect that we have to keep an eye on for next year is another vaccine is being presented by Gilead at ASLD, and this is in a preclinical macaque model using their new prime boost viral vector strategy, which is a combination of Pichinde virus and LCMV virus, and they are expressing variants of the core polymerase and surface antigen. And so basically the macaque studies show that they're getting good responses to the core, the S, all the antigens within the vaccine, and also good induction of anti-HBs in the macaque model. And then the next 3, and I put them in here because the next 3 focus on the exact same aspect, is PD-L1 targeting. So Aligos has a small molecule PD-L1 inhibitor orally delivered that has shown some efficacy now in a AAV HBV mouse model. They also have developed a siRNA, a GalNAc conjugated siRNA targeting PD-L1. And again, this is in the AAV mouse model. They've shown suppression of PD-L1 with some impact on HBs antigen. And then lastly, Arbutus has their PD-L1 HBs antigen, or sorry, PD-L1 small molecule AB101, and they've done some preclinical studies in combination with siRNA. So the idea of driving down siRNA and then coming in with immunomodulation. And they've seen good reductions the AB729 does induce good reduction of the HBV S antigen in the mice. The AB101 didn't result in changes in the HBV markers, but the combination actually increased liver-specific T-cell responses 5-fold in this study. So that is where I'll stop. It was a quick one, and if anybody would like these slides so you know what to look at, I'm happy to send them to you, and hopefully we can incorporate some of this into our discussion in the next session. All right, thank you.
Thanks, Adam. You just saved us all a trip to Washington. That was great. That was a really... Adam, stay up here. Stay up here. Don't go anywhere. No, you're going to sit beside me. So come on up here, and Georg will invite you up. No, that was a great preview to the meeting. And we know some people are leaving to catch flights to get to Washington now, so that's why we changed the scheduling a little bit. But we're going to go into the panel discussion, so please, if you have questions for the speakers that just spoke, and as well as really any other points of conversation. And for those online, remember to submit your questions through the Q&A. Maybe while we're waiting for the microphone to get over to the speakers, we do have actually a question online. This is a question for Stuart, and the question is if you can provide your thoughts on why you think Bepi works better than the GalNAc conjugated version.
So question why we think the non-conjugated works.
Yeah, exactly.
Yeah. So we're still working on it, but the hypothesis is that there's more than one cell type involved. So the Bepi in non-parenchymal cells is activating innate immune responses in the liver, and those are contributing to the antiviral effect. The other possibility is that a GalNAc conjugated molecule is shuttled to certain compartments in the cell and doesn't necessarily encounter viral RNA in the same way as it might encounter somatic derived RNA. So that's the other possibility. We've got in vitro and clinical studies that are helping to gather data. But
did you ever try putting them together?
Giving both? No, we didn't. It was from a practical point of view, it was hard work to continue both studies, especially when the whole field was pivoting towards GalNAc. Sure. So it would have been very interesting, but actually we were scraping Bepi off the bottom of the vial to finish the proof of concept study to get the data. So we haven't, but it would be very interesting.
Thanks. Bob.
It's been a great meeting, and thanks for this summary. I wanted to know about the endpoints meeting that was in Washington, D.C. Have they made any statements since then? There's these rumors that there's going to be this back off and a reset towards some type of durable viral suppression, and how does that affect drug development?
I mean, I don't think they've come out with any follow-up from that. There is a session at ASLD that's actually completely focused on the summary from the endpoints conference. I can't remember which day it's on. I think it might be Monday.
Do you believe we should do a reset and get rid of this S-loss concept at 40% or higher?
You got to target that question to somebody. There's probably some varied opinions across this table.
Anybody want to field that?
Anyone want to answer?
What are your thoughts? Because I mean, it impacts maybe endpoints for your studies more than anyone, right? So thinking about what you want to call a cure. Anybody dare to touch it?
I'll dare. I think I'll probably ask questions back though. I think I think the first question we would have is what data are there to support that the backed off endpoint actually delivers clinical benefit from patients? And then the second one, maybe you know best yourself, what's the patient and advocate viewpoint of an intermediate endpoint?
Can I maybe follow that up? Because I was going to ask a question to Barbara, and it sort of links to this, but about using some of these tools for transcriptionally active cccDNA, particularly RNA and correlated antigen. Do you know of any efforts to try to validate these against outcomes rather than, I mean, you've shown nicely about validating it against cccDNA transcription, but what about against clinical outcomes?
Yeah, not to my knowledge. I think we have to make an effort to include this test in the clinical trials, and also implementing some FNA in order to have both sides, the intrahepatic and the serum biomarkers. So definitely, we have to do that because I think preclinical data, validation data are quite strong and solid now, in particular for correlated antigen. You heard a lot of hints about that today. And for serum HBV RNA, I think we have to be cautious about the assay that we are using and always be specific about that. And really, I would really like to see a side-by-side comparison between the Abbott and the Roche one and see what happens and see what clinical and biological information we can get from them.
So to people that have biobanks with samples, I think this is an important question. I mean, these can be done on serum or plasma, and sort of to Stuart's point that I think it's going to be hard to get regulators to move endpoints until they're sure that they actually correlate with clinical outcomes, and these markers probably do. And I think there are limitations to S antigen as using it as the only marker of cure. Other questions?
So maybe I want to come up with a question maybe for Michael and then Grace, right? So and then Emily as well, because these CAMs that Arbutus showed didn't show any interaction. Do you think there's a difference in the type of CAM that we're using with the siRNA? Do you think it was something unique to the Janssen molecule, or is this going to be a class interference? I mean, I'm happy to hear from anybody first. But maybe Michael, you're starting.
Maybe not an answer, but a disclaimer. Whenever I say or share data, it's about 6379, right? That's it. And this is, I think, a very powerful CAM-E, and it's still first generation CAM-E, so I would not make any speculations about classes. But what we have seen looks like consistent, and was a good reason for us to take a decision. But I think others comment on other compounds.
Yeah, I think, it's there's really no answer now, right? It's, that's what we see is what we observed. And also, I think, Adam, you showed for the Arbutus collaboration study with the Bepcorvir with Arbutus siRNA. It's a little different. It's not little different. It's different, and could be speculation. Could be structurally differentiated, and or could be something else. At this point, I think it's just going to be, further explore any possibilities and continue to generate the data to see.
Can I just add, Michael, just you heard Mark Sulkowski's sort of speculation this morning about, especially, I mean, it is a CAM-E, so it's empty capsid, so you would, at least in theory, be accumulating RNA in the cell. Is there any merit to that? It seems like something that might happen for a while, but not long term. So any thoughts?
Well, in absence of better hypotheses, I think it's certainly something to think about. What I would be cautious about, in theory, the siRNA should block all production, so I would not expect too much of the accumulation downstream if 3989 does its job. I'm not saying I exclude it, but it's not screaming right now.
Yeah, you'd think that over time you'd sort of overcome that problem if you, with continued dosing, but you would think that some of your, I mean, actually you could evaluate that in vitro even, just see whether the combination, I mean, you looked at the DDIs, but whether there's actually, I mean, you could look at complexes and whether they're actually accumulating or using up your siRNA effectively.
Well, also with the DDI, we have to be careful, right? It's plasma PK,
Yeah, true,
which has
true.
no impact. And I don't think the siRNA is telling the full story in plasma. It really is about what will happen in the liver. And we also have biopsy studies ongoing, also sub-study with looking into drug concentrations. I think there's a lot unknown yet.
I had a question here, maybe for Barbara or for Grace. Really, can we use pgRNA levels to help us decide when to stop and which patients can stop therapy? Because if I remember from the initial ABI studies, all patients who met the stopping criteria were suppressed on entecavir and VBR. And all of those patients, I believe, were TNA negative, pgRNA negative, and almost all of them relapsed very shortly after stopping, after the withdrawal of therapy. So is pgRNA a good marker for stopping therapy?
This is a very good point.
Go ahead, please.
No, go ahead, Barbara.
Yeah, it's a good point. I think it's a start. It's a start. We need more data about that. Also because when you have long-term treated patients, there are most of them are negative for serum HBV RNA quantification, but that doesn't mean that then they will not have rebound. So the limit is very gray. So I wouldn't choose it now as a strong indicator. I think we still need more data with different assays, standardized assays, before saying that. But it's a good start, yeah. Probably the combination of correlated antigen and RNA would be more solid.
I'll follow up with another question about the CAMs, and I guess with these more potent next agents coming, do you think this second mechanism takes, the time course is any different? The first mechanism of action is very straightforward, target engagement, but what about blocking of cccDNA?
Yeah, certainly. I think for the second mechanism of action to take effect, it will take some time because we also know there's integrate S antigen, and that would not probably show in a short term. And for the effect of the drug, you have to be able to deplete those to be able to see the effect on the S antigen reduction and the loss, and also other antigen movement as well.
I mean, maybe we had a couple of topics here sort of in the end, then if there was no other specific questions at this point, and some concepts that I think have been sort of troubling the field, and maybe they're changing, like particularly this idea of plateauing for the treatment, right? I think it seems like the 6-month window got us to, it was difficult to drive down further. And I don't know if that's, I'd like to get everybody's opinion on this, particularly those doing combinations. Are we actually plateauing, or and we're adding more on? Can we drive sort of this viral suppression down? Because now, I mean, some of these triple and quadruple combinations, you're getting to LLOQ in some of these assays. So is this idea that we had plateauing with the siRNA alone, is that something we need to move beyond now? Or is that something that's still realistic? I mean, maybe Michael and Stuart can start the discussion.
Do you want to start? Do you want to go first?
Okay. Well, first question is, which parameter are you looking at when we talk about plateaus, right? We have certainly different patterns. If we focus on S, I would say it smells like a plateau, but it certainly isn't. So we have, in individual cases, we have patients who show clear reduction, continuous reduction until week 48, and then we stop. So I think it is not a clear or definite plateau, but obviously, if you draw a line, it could be 3-4 years of treatment until you get to negative, and that's something where I would say combinations are probably the best approach to lower S, but then add help on top, whichever it is. Stuart, you take it from here.
Yeah, I think there's a rational approach, a clinical trial approach. You could try and do this rationally with pharmacology and modeling, and think about how saturable a risk complex is, and whether you just can't get enough risk activity to get down to zero, versus the opposite, which is an ASO, which can maybe continually break up RNA, but very hard to dose high enough for every patient. And you have to integrate that pharmacology with an idea of the stoichiometry of these molecules, plus the heterogeneity of hepatitis B. So we have to think a lot about, does our patient have a large number of cells, each with a small number of copies of viral DNA or RNA, or has it got a small number of cells with a large number of copies? And how will the different mechanisms play out in those? And then trying to work out how the combinations will make a difference there. There's potentially some fantastic computational pharmacology that could get the answer, or perhaps we do the clinical studies and see what results.
But I think it does raise a question. I mean, it was very helpful in the hepatitis C field to do some of the modeling to actually try to figure out mechanisms of action to really understand, because I would agree with you, Michael, it's not exactly a plateau, but it's definitely a change in the slope. There's sort of a biphasic decline at the very minimum, and trying to understand what the difference between those two phases is with different modeling parameters, I think would be, I don't know if you've done that, but people like Alan Perlman and his group have really been helpful in the HIV field and hepatitis C field to understand how drugs do and don't work by looking at the kinetics. So it just might be I don't know if you've explored it with the siRNAs, and maybe, I don't know if you want to comment from Arbutus as well, but.
We do have a very active modeling group within the team. I don't think we have yet really published on it. Certainly an important contribution. And I agree with you, there's a second kinetic starting after 16, 20 weeks of treatment. I am not enough an expert, but when I talk to the experts, it could simply be a numbers game as well, that we are looking into kinetics where if we look at the log reductions, there is certain limits that we cannot increase or reduce further about. And we should also not forget exactly what you say, the reductions that we're seeing, in particular in the beginning, are dramatic, right? We're talking about fold reductions, massive. And not just small trends. But I refrain from going further because I'm not expert on that.
And so, Georg, I'll bring. Sorry, go ahead.
Sorry. I just wanted to mention also, I mean, I think people are focused on the S antigen readout and looking at what might be a plateau for the siRNA, but, I think our HBV T cell data suggests that there is something happening even if the S antigen seems to have plateaued, right? So there's activation of HBV T cells. And so I think that's, those other factors need to also be considered.
Yeah, and I was going to bring Georg into this discussion too, this idea of, because this is when to start sort of the immunotherapy is the question on these sort of strong antiviral backbones that are coming in. And, do we do this, do you think it's the 6-month time window when things sort of are maybe at their lowest during follow-up, or follow out longer? Do you have any idea of how the T cell response or restoration might be affected based on the duration of suppression?
Okay, that's a great question that I cannot really answer. I mean, I think it definitely takes more time, than what we are seeing today from some of the antibodies, where you can see it in a day, more or less. It will not be that fast. I don't think we know very well. I mean, we do know that, in, let's say, an acute infection, you see rather dramatic changes within a few weeks. Obviously, when we have an intervention, we don't know how fast it goes, because you start, if you have an acute infection, obviously you have this dramatic expansion of T cells, and it goes really fast. And that's most likely different when you have a resurrection of someone or something that has been exhausted and dysfunctional for a long time. But I think that's, I don't think we need to be super narrow in our measurements. I think we have some time. So, for example, I would most likely say look at, I think 6 weeks, 3 months is most likely fine. If we see changes, we can still always say go back later or so, or make other studies where we go more granular. But I would rather give first a little bit of time to be able to see something. And also, obviously, we can look at the readouts, the clinical data, right? When do we see some kind of effect? I don't think we need to look before there's any movement in the clinical data. So we need to learn a bit about it, but I don't think it's something where we should be too worried about right now, actually.
And what about if you throw checkpoint inhibition into the mix? So you reduce antigen, checkpoint inhibition, and then a therapeutic vaccine has been so effective in the mice. How does the timing work there?
That's another good question. I think when we thought about these, and we have the ACTG trial that unfortunately has not recruited yet, but we made a plan for an analysis. And I think we thought we would have a first look at 4 to 6 weeks, most likely, to see what happens. On the other hand, one might need multiple rounds. And then obviously the big question is still, it's rather different from the tumor, right? We go in these immunosuppressed patients, not immunosuppressed, we go in these patients with suppressed viral load, and we don't see, for example, the highest classical exhaustion signature, et cetera. It's not even totally clear yet, what to expect there. And can you expect anything without a vaccine on top of it, for example? So this is going to be all really new territory, but it's completely different from the cancer. And then obviously the question I would like to add at this maybe is then also, when you think about the readouts, obviously, what we do, and we talked earlier that there's always this compromise between doing a lot, but then needing so many cells, that's really a problem for the trial. But at the same time, and I had actually some questions for Emily on this, what they did, because I was a little bit worried, to be honest. If I understood you correctly, you used whole CD8 T cell PD-1 staining as a marker for T cell exhaustion. Is that correct? Just you phenotyped whole T cells from PBMC, right? Or did you use?
Yes.
Yes.
This is global. Yes.
Yeah.
We're sorry.
Yeah.
It's a little lag. I apologize. So, I think we're interested in exploring, looking at HPV-specific T cells, but currently we don't have the tools. The tools are out there, but we don't have, we're working up them ourselves.
But then I would just like to warn them, or to say caution in then doing this kind of assay and saying it has something to do with T cell exhaustion of HPV-specific T cells, because frankly, it does not have anything to do with that, because we know that in a chronic patient, you don't even reach, when you add all CD8 T cell responses to HPV together, you don't reach 1%. It might be 0.1%. So obviously, measuring in whole PBMC then your PD-1 levels, if you see a change, it's some random event, we don't know what it is, but it has nothing to do with HPV, and I think then it's rather not done, to be honest, because then it's confusing to me. And we need to be very careful and I think be very frank when we discuss these kind of data, also with the ELISpot, for example. Most of the responses were I don't know, I saw something like 40, 50 spots per million. I'm not sure you told us how many cells put in, but if we say per million, that usually means we had an assay with 200,000 cells. So we're talking about something like 16 to 20 spots. And then what's the background, etc. So this is all at the extreme level of where this assay can even be specific or be considered seeing a response. And so I know it's always tempting to say we see, you say evidence of T-cell restoration, but I think we need to be self-critical to be reasonably confident that what we see is actually restoration, or whether we see noise, or we measure something that maybe has not so much to do with the T-cell response. And that is something I think we need to have all conversations, because a lot of people who are responsible for these trials maybe, are not so very intimately involved in immunology, but I think it's really important to do that.
Yeah, so I think your criticisms are well taken. I just wanted to point out that we don't, for the fluorospot assay, we do not do any ex vivo expansion. So this is ex vivo assessment of cells. So that's one thing I think to keep in mind when looking at the spot numbers. I think ultimately, the T-cell data is only going to be supportive. I think everyone probably here acknowledges that the clinical outcomes of these subjects on the study will actually be, the proof in the pudding, so to speak. So I think, the longer term follow-ups assessments that we are currently conducting, we and others are conducting, will be informative in that regard.
Yeah, I want to switch gears actually a little bit and ask Barbara a question about some of the biology, because I mentioned it a couple of times, and you can see it in multiple studies with the siRNA drugs. When they're stopped, the rebound is low and ALT doesn't typically go up. And Massimo sort of touched on it before. I mean, if you're targeting X, you get the SMC5/6 come back, and you get silencing of, well, I don't know if it's silencing or just, it doesn't sound like it's actually silencing of the cccDNA in this context. So just to get your sort of virological opinion on what's happening here. So like these siRNAs, how long does it take potentially for X to come back in that SMC? Do we have any idea how long it takes for that SMC5/6 complex to be degraded again, or how robust it is? Because from the data, it seems very robust, right? You stop the siRNA and you get this very, very slow rebound.
Yeah, so it's speculation because we don't have any data about that. So I'm basing on the very nice work from Maura D'Andri's lab, just published in GATT. So where they show that if you target the X region with an siRNA, you recruit again SMARC5/6 to cccDNA, and indeed you block the transcription of cccDNA. So if it's silencing or not, or which type, we don't know. So we need more data on that. But definitely it is permanent. So unless you have new rounds of infection, so new formation of new molecules of cccDNA, the cccDNA which is there associated to SMARC5/6 is permanently inactive. So I don't have any idea about the half-life of SMARC5/6 complex, but it's a dynamic situation where these factors are attaching and detaching the cccDNA molecule, I imagine, so it's much more complex. So I think that the duration really is associated with the number of affected cells in the liver, and this influences the rapidity or the kinetics of new rounds of infection and then productions of new HBx that could degrade again SMARC5/6 complex and have new transcription. So another actor in the game is the X coming from integration, because in the humanized mouse model from Maura D'Andri, you don't have any integration, so they couldn't study that. So it's X coming from integration able to degrade the SPAC5/6 or not. So we don't know which kinetics, etc.
But given that that's an irreversible blocking of cccDNA transcription, which I did not know, is combining it with an entry blocker, I mean, that seems like it would make some sense.
Exactly. What they did is to add MRCP to the combination with the CyRNA, and they had no rebound of HBV replication. It was really black and white.
That's very interesting. And maybe just on the talking about Mercludex or bulevirtide, but just a question for John, I guess, just so about the 2 milligram versus 10 milligram dose, and just a question about my understanding, but I want to make sure I'm right about this, is the bile acid saturation, blocking of bile acid uptake is saturated at the 10 milligram dose, but not at the 2 milligram dose. Is that correct?
Well, it's definitely saturated at the higher dose level, but it also there's good occupancy at the lower dose level as well.
I guess the reason I'm asking is that, we've seen a pretty nice safety profile with the dosing duration, but as you pointed out in the European label, it's kind of like dose as long as you think you need to, which might be indefinitely. And while I think blocking bile acid uptake transiently is not really a big problem, blocking bile acid uptake, if it's really saturated for years, potentially could lead to more significant concerns.
Yeah, I think that's definitely a factor that went into at least the initial review and selection of the 2 milligram dose. And as I showed with the phase 3 data, that the benefits of a higher dose are really not very clear. And we also have now intrahepatic data showing that. But the greater question is the bile acid elevations are asymptomatic, but we only have limited short-term data. So what happens with long-term, we don't know. But we do know there are individuals who have a rare genetic disorder where they don't have the transporter, and they live their entire lives with elevated bile acids. The mechanism is different in that case than it is in other hepatic diseases, but they do fine. What we don't know is in certain diseases, like in renal impairment, it's not that bile acids are renally cleared predominantly, but there is a component of renal elimination, and it's in the label that whether you might have elevations in underlying renal impairment. We do have data in mild impairment that it's not a factor, but we will look at it in severe and possibly moderate renal impairment. But the long-term implications are unknown. This is a simple answer.
Okay, thanks. Have a question?
Yeah, maybe reverting to the previous discussion. So when we're considering all these combination studies, for example, between direct-acting antivirals and immunotherapies, there are quite a few of those ongoing in a strictly sequential manner, most of them starting with the direct-acting and continuing with the immunostimulation. And now we have heard that some of those compounds have shown some immunomodulatory functions. And would it be something that makes sense to actually evaluate this in kind of concomitant schedule that essentially leads to potential synergism between the innate activation of this compound and immune stimulation coming from the immunomodulatory part of that regimen? So what needs to take place? Is it only the safety that's blocking that?
Yeah, I mean, I do think there is some value in sort of concomitantly, so concurrently starting these different therapies. I've sort of looked at the data. I mean, I think too that just reducing the S antigen, it doesn't necessarily, or the antigen doesn't necessarily give you a large boost. At this point, I think it was just logic that we're driving down antigen and then coming in with immunotherapy. It sounds nice and it's rational, but doing both at the same time, you might get sort of a snowball effect potentially as well. I mean, especially if you have a very strong therapeutic vaccine, because I don't necessarily think that the level of S antigen is going to impair the responses to that. I think you can do it, the one key aspect that I would want to avoid when coming in with an immunomodulator is potentially coming into patients with hepatitis, with active hepatitis. It tends to not be ideal for the immune response to respond further in the presence of inflammation, right? So that's sort of the one metric that I would be cautious of in sort of co-starting different therapies. But I mean, I think, you know, it would certainly shorten duration of some of these potential strategies as well, and it may be just as or more effective. I mean, it might depend on the combination too, but I think that if you have the right drugs, it's worth looking at.
I guess it'd be interesting to know what you or Emily or Georg think about what's the right amount of antigen to have. Half the time we're talking about driving it down as low as possible, and the other half of the time we're talking about boosting immunity that requires some antigen to be present. So how do we work out the right amount of antigen?
I mean, I think for well, it's a good question, Stuart. No, I know. I mean, you know, they impact different aspects of the different therapies, particularly in how the responses. My feeling is that a therapeutic vaccine will perform in the presence of antigen, and then whether or not that response has an effect in the liver is potentially a different situation too, and that might require some other modulation in the liver that would make it. And so, because all these patients already have T cell responses, or most of them, that is very low and very rare, so in terms of the antigen that has to be present, I mean, whether or not you can, even if you get in the plasma below the lower level of quantification, the LLQ of these assays, I mean, whether or not this is all gone in the liver, and eventually they have to be stopped to know that it's a finite treatment, and boosting that response and having those T cells in the liver and understanding if that's going to respond, because when that antigen comes back, you have to have that response, and you're going to be able to tell. I mean, it is a tough question. My feeling is that it doesn't necessarily have to be driven down to an undetectable level to induce a decent immune response, but you do have to have antigen if you want the immune response to see the infected hepatocyte. And hepatocytes aren't good antigen-presenting cells, so if you have very few antigen, then it might be difficult. But again, this comes back to these functional cure patients. They still have antigen in them. They still have enough to have immune complexes in their peripheral blood, but they're still considered functionally cured because they're S antigen negative and anti-S positive. So I can see Georg. I'm going to get off the hook here, and I'm going to pass it down to Georg.
Yeah, I mean, obviously the short answer is we don't really know, we speculate, but I think one scenario I could see is drive down the infection, the antigen, as much as you can. Then, if needed, and most likely it is needed, go in with something that's allowing the T cells, if you talk about those, to be more functional, to recover. So, for example, PD-1 therapy, checkpoint, could be something else, potentially. And then, don't worry about the antigen, but go in with the vaccine. So then stimulate these now more amenable cells to have a good response, and then stop the treatment that lowers the antigen and see whether we can now contain. I mean, I think that would make a lot of sense if we can do it.
On that note of orchestrating a very nice symphony, it's getting all the pieces to play in order is very challenging. But I think, so it's been a great discussion. Thank you to all the panel members and the speakers. A really good session and a great day. So we're going to wind up the day, and I think Adam has a few closing remarks to close out the meeting. Thank you.
Because I could tell it's been a good day, everybody, and it's been fantastic after a couple years of having it online. Obviously, some great discussions all day long, and it's been fantastic to see the data that is accrued, and then what we have coming up at ASLD. So, just to wrap things up, every year it wouldn't be possible without our sponsors, so we have to make sure that everybody is recognized, and we express our gratitude to those that have supported the meeting and also to the delegates that have come and taken part in the discussions and sort of help move this field forward, because obviously we can tell there's still a lot of big questions, more coming sort of every time we have a meeting and we look at these abstracts and we get the next 24 weeks of data. And, it's a fascinating time. It's an exciting time. And so I just appreciate everybody's effort and also for our workshop partners. And so, again, please participate in the post-survey workshop. You'll get that, and there is a certificate of attendance necessary if we need it. And there's our beautiful group photo. I'm sure you can have this emailed to you if you would like to have it. So thank you, everybody, for participating in that. I know it's not everybody's favorite thing to do. And I guess this will wrap it up. I have one other message, that we do have some space left in the networking dinner. If anybody would like to register for that, you can see them out there at the registration desk. So it'll leave from here at 8:15. It's within walking distance. Sorry, I saw 18:15, 6:15. It's been a long day for me as well. So I really want to thank everybody again, and I really appreciate everybody's attendance and participation. It was great to see all of you, and I look forward to seeing all of you in DC in a day. So thank you very much.